So, candidate 1, can you ask for mouse?
Sir, I've requested.
Over to you. So, this is a 77-year-old female, known congestive cardiac failure, and uh, patient is losing weight, and they have asked for this CT.
Sir. So I've been provided with axial CT abdomen, including lung bases in post-contrast CT abdomen in portovenous phase of a young female who is losing weight and is a known cardiac patient. I'll take a moment to scroll through the images quickly and then start presenting my findings. Meanwhile, I can appreciate small amount of left-sided pleural effusion with ascites in the upper abdomen. IVC is significantly dilated. That can represent her cardiac failure status. The liver in these cuts appear unremarkable. Spleen is unremarkable. Portal vein is of normal size. There is significant mesenteric congestion. So in these images, I can appreciate this significant dilated IVC. And also, I could appreciate an abnormality in the right kidney in the mid and lower poles. However, I'll quickly scroll through the last image and then come to my point of interest. There is significant abdominal pelvic free fluid. The bladder also appears to be thick-walled. Prostate appears bulky. That might be causing the outflow obstruction at the urine bladder level. So coming back to my area of interest, I would like to focus on the right kidney. So I could appreciate there is an ill-defined infiltrative hypoenhancing mass lesion at the mid-pole of left kidney. It appears to infiltrate the renal pelvis and extending into the left renal vein and subsequently into the infra part of IVC. The same density and the same distension of the IVC is still noted within the intrahepatic part of IVC. I'm trying to trace it down cranially so that I could see if this extends to the heart as well, which I can see, yes, there is the extension of the thrombus into the right atrium as well as into the right ventricular across the atrioventricular septum. So keeping in these findings and history of weight loss, I would like to investigate. I would also like to inquire about if the patient is having any history of hematuria, if patient is also having any hematuria. Also, I'll take, in my routine practice, I would complete my scanning while looking at bones and whole of the lungs to look for any distant mets. However, the liver appears normal. I could not appreciate any significant lymphadenopathy. The thrombus also appears to extend below the renal level into the also into the common iliacs. But I would like to correlate my findings with Doppler study as well to check if there's femoral extension of the tumor as well bilaterally. So in summarizing, this is a right renal neoplastic mass extending into the IVC with tumor extension into the even into the superiorly into the heart and distally till the bilateral common femoral veins. I will immediately inform the physician. The patient needs a detailed echocardiogram to evaluate for the cardiac status and Doppler studies of the bilateral lower limbs to confirm the tumor status, thrombus status of bilateral femoral veins. Urology consult should be taken for the right renal mass. and the patient should be referred to the MDT for further oncological management, and full stage CT should be performed.
So I think you are confusing right with left. You meant right side, isn't
The
it?
right side, yes, sir.
Okay. So if this is a renal cell carcinoma, what is the staging of this renal? Give me the T staging.
Considering that there's supradiaphragmatic involvement of IVC as well into the heart, so definitely it is 3B. I could not appreciate any in the lung basis. I could not appreciate on soft tissue densities, so I'll definitely look for the whole chest to look for if there is any distant met. Also, I could not appreciate the lymph nodes, but I'll so it is T3B with M0 in this study unless there is any lung involvement and no nodal mets.
So what are you worried about in the femorals? What worries you?
Since there is distal obstruction of the proximal obstruction of the IVC because of the tumor extension, there can be stasis and there can be bland thrombus in bilateral femoral veins as well. That needs to be investigated with Doppler for further confirmation. Either she's developing any DVT.
Okay, thank you. We will go to the next case directly, and then I'll give you a feedback.
Sure.
66-year-old.
Sir, I've been
Pain,
present. Sorry, ji, sir.
pain and swelling of knee.
Sir, I've been presented with frontal radiograph of a right knee of a 60-year-old male patient who has presented with pain. In this, I can appreciate some degenerative age-related changes seen as reduced medial tibiofemoral joint space, subchondral sclerosis, and few osteophytes. There is a density along the medial femoral condyle, along with this looks like a calcific density. Proximal to it, there is another faint density coursing along the medial aspect of the distal femoral shaft. For the rest of the areas, I cannot appreciate any fracture in the tibial plateaus. I cannot appreciate any bony fragments along the fibula and tibia. Bilateral femoral condyles appear unremarkable, no subchondral insufficiency fracture. Patella in this view appears normal. In my routine practice, I will adjust the windows to make the visibility a bit clear. So I would also evaluate the patient on the other orthogonal views. Thank you so much. I'll also evaluate this calcific density on orthogonal views to check. Okay, thank you. This appears to be projecting posterior to the femoral condyles, and in this projection, it does not appear to arise from the femur because I can clearly see an intact cortex of the femoral condyles. I cannot appreciate any. There's subtle haze along the posterior femoral cortex. I would zoom it a bit to see if it's a periosteal reaction. So this appears to arise discretely from the femoral condyle and more sort of a soft tissue calcification rather than arising from the bone itself. And And it's predominantly centered over the popliteal fossa. So it is dense homogeneously without any peripheral faint calcification. If the patient has having any history of trauma, this can represent a area of myositis ossificans. This can also I would in my routine practice I would compare it with if there is any prior X-rays to check if this was present or if there is any interval change in the calcification and density,
There
because
is there is no history of trauma and there is no previous X-ray.
sir, in an old patient, I would also be worried for any sarcomatous transformation with calcification in it. The cortex appears.
Would you
There's
like
certain.
to see anything
Sorry.
else?
Further, I would advise the patient to have an MRI knee done, but in this,
I'll show you.
sure. So I've
You
been
can
presented with axial stir images of the same patient, axial view. I'll see.
you can ask for the
So
mouse.
yes, I have to ask again for the control. So I have requested, please. Thank you.
Yeah.
In these axial images, I can appreciate a small amount of patellofemoral effusion. There's some amount of soft tissue edema on the medial aspect of the medial and posterior aspect of the femoral shaft. That soft tissue, that calcific area is redemonstrated on these images, seen as stir hypointense signals demonstrating calcification. So this I'm trying to establish its association with femur, and also there is medial patellofemoral ligaments appears to be disrupted and with altered intraligamentous signals. This appears to arise from the posterior medial femoral condyle cortex, where I can see a defect as well in the cortical outline of the femur.
Give me your conclusion.
So this appears to be a detached bony fragment from the medial femoral condyle, along with ligamentous injury and effusion. The patient needs to be referred to orthopedic clinic for further evaluation and management.
Okay, thank you.
Thank you, sir.
So what I'll do is that I'll go through both cases and then I will go through the cases on Osiris. But first of all, let me just show you the solution or the diagnosis, both the cases.
Sir.
So the first case was, of course, renal cell carcinoma with extension into right atrium. A bit of fine touch because I don't know if you realize that you were actually saying left and you were meaning right, and this happens in the exam. So it's a human element. You don't even realize what you were doing. I'll go through the case and then we will discuss it. You
Sure.
so the renal cell carcinoma, I asked for staging. One feedback is that I I did ask you T staging. So you have to
Sure.
listen to that. And when I'm talking to you, there is no need of responding because otherwise there is an echo. So just keep silent, please, unless you want to ask me something. So there's no need of saying yes or acknowledging. Thank you. So the point is that I did ask you T staging, but then you start narrating I will look at the lung, I will look at this, I will look at you had already described that. I was asking you a extended question which was T staging. So though you were correct, but I think it was not needed. The N staging, and you were again describing that I'll look at the lung, etc. So this is T3C, which you got it right. Rest of the things we will discuss it with the case. Case 2 is hydroxyapatite deposition disease of the knee, which is HAD, HADD, HAD. And so I've selected two cases, I think, of calcification today, and just to because I always feel that people struggle with these cases. These are simple cases if you know them, and if you don't know them, then the eye see what the mind knows. That is what happens. So soft tissue calcification can be dystrophic and it can be metastatic. This is the differential diagnosis. HAD is not mentioned there. You can include HAD. I'll come back to that. And what is it? It is a disease of uncertain etiology characterized by periarticular and intra-articular calcium depositions. So periarticular and intra-articular. And shoulder is the most frequent. And I'm sure all of you must have seen many cases in the shoulder. Usually middle-aged, it can cause localized pain, and our patient did present with pain and swelling. So it can be tenderness, variable limitation, and often these patients can be symptomatic also, asymptomatic also. So please remember, in the periarticular soft tissue, they specially are deposited, this calcification is deposited in the tendon. So this is a key point to remember, tendon. And but they can also involve the capsule or the bursae. They can be mono as well as poly articular. So shoulder is the most common, supraspinatus is the most common, but they can be at various sites. For example, gluteus medius along the femur. This one is along the fibula, and they can be around various sites of tendinous attachments, elbow, wrist, hand, knee, ankle, foot, spine. Everything can happen. And so the calcification has got various phases. And key point to remember is that it can resolve. There is a resorptive phase. It can vanish. So there will be calcification which will vanish. So and at a particular stage, it can mimic a periosteal reaction also in that. Uh, Now, it is usually rounded to ovoid calcification in soft tissue with well-defined or ill-defined margins depending on the stage of the disease. Treatment, conservative, needling can be done, corticosteroids, etc., surgical remover, and it can cause also complete destruction of joint. Milwaukee shoulder was, described in this category. So a few examples. I'm sure all of you must have reported this. The only thing is that supraspinatus calcification, and please remember that many a times these patients are extremely symptomatic. This one, if you see anatomy, it does not correlate with the supraspinatus. So this is in the bursa, subacromial subdeltoid bursa. You can imagine once you know the pathology, you can make the radiology out of it. This is along the lesser trochanter, and you can see that it will cause edema, and that is why there can be pain, etc. This one, another one next to supraspinatus, and then there is edema along it. One thing which I did not ask you for the simple reason that you did not reach that point, but I was actually uh, if you ever had got at that point, I would have asked a bit of anatomy on that MR. Actually, there is a tendon there, a conjoint tendon, which is pes and serenus, which is the conjoint tendon at medial aspect of the knee, which includes sartorius, gracilis, semitendinosus. There are so many different mnemonics, which I'm sure all of you must have read this in your MBBS, sartorius, gracilis, and semitendinosus. So this is how the anatomy is, and this is the anatomy which I did not ask you, but I would have asked you if you had reached that point. So if you see these tendons, this is the sartorius tendon, then is the gracilis, and semitendinosus is the posterior. And then there can be a bit of variations, but having said that, there is a conjoint tendon, which, this is the tibial plateau, so a few centimeter below that, it is attached here. And our calcification was somewhere in this region, the calcification in our patient. Now, this is the anatomy. The anatomy is sartorius, SGS, right? Sartorius, gracilis, and semitendinosus. So this is the anatomy. On the other hand, because the differential, you did mention myositis, uh, but in this, I also want to teach you how to differentiate it with myositis. Please remember that in your Chapman, there is a differential diagnosis, soft tissue ossification. Do not confuse it with soft tissue calcification, which I already showed you. And many people in the exam, they do this. So you should have clear-cut concepts. Ossification means, there is ossification, means there will be metaplasia, there is metaplasia, and within the soft tissue, there are ossification means you will see bone trabeculae. In real world, at times it is difficult, but in the exam world they will show you cases in which there will be trabeculation. So for example, this thing, a patient who is paralyzed and there is a lot of ossification around the joint, it's a very popular exam case. You must remember that. Parosteal osteosarcoma is, of course, a tumor which has got a pathognomic type of appearance. But you should have an absolute clear-cut idea about myositis ossificans. And please remember that it is fine to ask for history of trauma. Many of the times, the history of trauma is too trivial and they don't know, remember. The patients don't remember. And so basically, the key point is that osteoid matrix, it starts as ill-defined peripherally, and then it extends to the central portion. This is the key point. And please remember that once it is developing, at that point, it will be difficult. If you do an MR, you will be in trouble. Now, this is classical, that you can see that there is peripheral calcification and lucency. A few months down the road, 3, 4, 5, 6, 7 months down the road, all of this will become calcified. At this stage, the key point to differentiate between this and the HAD is that this is ossification is peripheral and there is a lucency in between. Now, at this point, if you do an MR, you are going to be in trouble because it will appear very aggressive, and even a biopsy will be very tricky. They will say that we are worried about malignancy. So the key point is that follow up on on uh, on plain film. Plain film is the best modality, and it is a self-limiting condition. And this versus this, and over few months it will become this. And This is a chart from StatDX that how long it takes for whole of the mass to become decrease in size and seize, and it will have a mature cortex. So key point is that initially don't do anything. Must avoid biopsy. So here you are, this thing, and look at this. Many a times post-trauma, as in, let's say, post-hip surgery, hip replacement, you will find these things. These two are there. There is now, look at this. This is a classical exam case, which I just wanted to show you that look at this, what is happening. This patient is paralyzed. And you remember the differential which I just showed you. So this is ossification. It's not calcification. You can see trabeculae, you can see bone trabeculae like this. So this is a classical exam case and from paralysis. Okay, so let's quickly go through your cases. Now, this case is a renal cell carcinoma. We can see, this mass which is invading the cortex as well as medulla. From there, it goes into the renal vein and it extends to the IVC. At this point, actually, possibly it is also going into this renal vein just till here. But I'll come back to the femoral vessels, etc. But now it is extending into the IVC, going all the way into the right atrium. Here you are, into the right atrium. Now, more proximally, we can see that here there is a filling defect. The candidate said that I will be worried about thrombus and I'll ask, Doppler, which is fine. Uh, but incidental, there was an aneurysm. It is about 4.6 centimeter. That is an incidental finding. So overall, uh, uh, you got it right. Just a bit of fine touch, as I pointed out. You were using the word left instead of right, and sometimes you were also correct. In the Viva question which I asked you, you there was no need of going into N staging or M staging. So the feedback will be to listen to the examiner very carefully. Now, this is calcification, and you have to develop your eyes to look at calcification, rule out any trabeculation, because myositis ossificans will, at a mature myositis ossificans, will have trabeculation. Now, which are not in this particular case. And on the other hand, if you see, because you have seen it on the X-ray, on the what we call the plain X-ray, you can see the anatomy. So this is the medial side, this is the lateral side, and here we can see that this is that calcification, lot of edema around it. And you can I showed you in a PowerPoint slide the various tendons. And so I am now gone more distally. This is fibula, this is tibia. And you can see these three tendons as I am coming up. You can see here you are. It is involving them. And if you want to confirm it, though I did not show it to you, but here you can see it, the anatomical location. So that is fine. So candidate one, thank you very much. Candidate two, are you with us?
Yes, sir. Assalamu alaikum.
So now this is your case of 41-year-old male. You can ask for the mouse.
Yes. Mm, okay. Yes, sir. So I have requested.
Okay.
Okay. I am
So
provided with.
patient has got swelling in the neck bilaterally.
Okay, sir. Uh, I am provided with axial MRI T2 weighted sequence. First, I will scroll through the entire stack of images and then I will comment. Uh, this is PAT-SAT sequence, and I can see uh, that there is evidence of bilateral hyperintense signals involving the parotid gland. Uh, Multiple T2 hyperintense, well-defined cystic areas are seen involving both of the parotid gland. The parotid gland appears to be mildly enlarged. However, it is maintaining its shape uh, in the form of its superficial and deep lobe. Uh, Largest cystic lesion is noted in the left parotid gland. Uh, I cannot see any significant mass effect on adjacent neck spaces. The lesion is medially, it is extending uh, up to the carotid space. Uh, Now I'm looking at the carotid vessels to see if there is any invasion. Uh, uh, so the flow voids are intact on both sides. Other than that, I'm looking for any lymphadenopathy. So few enlarged lymph nodes are seen at level 5 bilaterally. They are usually sub-centimeter. So in my routine practice, I would like to see contrast sequences as well. The rest of the cell neck spaces appears normal. The parapharyngeal space and the masticator space appears unremarkable. Uh, yes, the nasopharynx also appears normal, and the visualized slices of the brain parenchyma does not show any significant abnormality. Uh, so on this provided image, there is evidence of bilateral abnormal signals within the parotid gland with multiple cystic areas. Uh, I would, in this case, a possible differential could be related to this is likely uh, uh, due to HIV parotitis. If this patient has a history of immunosuppression, so this may be the cause. Other than that, sir, this could be due to Watson's tumor of the parotid gland, which is related to smoking. Uh, I would like to see contrast as well as the diffusion weighted sequences for further evaluation of this case.
Leave the mouse.
Okay.
This is post-contrast.
Yes, sir. Okay, I'm provided with the post contrast images, and I can see that uh, the gland bilaterally is showing heterogeneous enhancement. Uh, so the cystic area does not contain any solid component bilaterally, and they appears to be non-enhancing. I cannot see any necrotic lymph node or peripherally enhancing lymph node uh, in these provided images. I'm also worried about the other uh, glands. So I'm looking for the submandibular gland. So submandibular glands, they are of normal shape, and however, they are showing subtle contrast enhancement as well. Yes, bilateral submandibular glands also demonstrates cystic areas and of almost similar appearances. However, this cystic area also does not show any significant enhancement. In my routine practice, I also would like to see if there's an involvement of the lacrimal gland as well. This is almost bilateral and symmetrical areas of salivary gland involvement with the cystic spaces. Sir, I will add one more differential of Sjogren's syndrome in this case, and that could be due to an underlying autoimmune disease. Uh, so, uh, uh, Sir, I would like to see if any diffusion sequence available.
What do you want to see in our diffusion?
Uh, uh, so to see if there is any like abscess within that, so it may show central restriction. Uh, However, there is no peripheral
Okay, give
enhancement
me
of the
your
cystic.
final diagnosis. What is your final diagnosis? What is your
So if the patient has a history of autoimmune disease, so this could be due to Sjogren's syndrome. So other than that, if patient is immunocompromised, this could be due to HIV parotitis. And sir,
what is
possibly, sir,
HIV parotitis? What is HIV parotitis? What are the
sir,
findings which you see?
sir, bilateral cystic areas are seen within parotid glands
So,
bilaterally.
so that will be parotitis. The word parotitis means what?
So
Infection of the parotid gland?
no, sir, actually, it is something related to lymphoproliferative disorder. Maybe I'm missing the name of that, but it is related to HIV.
So what are the other findings which will help you make a final consolidated diagnosis, which you have to see in this case?
Sir, I cannot see, sir, any significant lymphadenopathy. So it that signifies that this is less likely to be any malignant etiology. Uh, and other than that, sir, there is no mass effect or any invasion of the adjacent neck vessels. So this is likely a benign etiology that is involving the parotid glands as well as the submandibular glands in this case.
Okay, this is your second case, 84-year-old pelvic pain.
Okay, I'm provided with the X-ray of pelvis of a 84-year-old male patient who has, I mean, the first thing which I can notice is that there is an evidence of hip prosthesis on the left side. And now I'm looking at the review areas. Uh, Bilateral, the right femoral joint appears to be unremarkable. And sir, I would like to zoom and window because I'm worried about the right-sided, left-sided sacrum. Sorry, because I cannot appreciate the arcuate lines
Leave the
in this.
mouse. Leave the mouse.
Okay,
I'll do it for you.
thank you so much. Yes, sir. I can see that there is a destructive lesion involving the left half of the sacrum, and it also has probably a soft tissue component involving the pelvis. Since I cannot see the normal arcuate lines, in this old age, I cannot see any calcification or any osteoid matrix. Uh, there is suspicion of subtle, tiny calcification, but I cannot see any definite osteoid matrix in this film. And other than that, sir, I cannot see any periosteal reaction in the adjacent bones. And so keeping in view these findings, the lesion also has a wide zone of transition. So keeping in view this finding, this is likely an aggressive lesion involving the left half of the sacrum and probably involving the sacral foramen as well. My differential diagnosis in this case would be metastasis. Other than that, sir, this would be a chordoma. Uh, so uh, 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 the third possibility, sir, could be of chondrosarcoma. So I will inform my finding to the referring physician and would like to see if any orthogonal review available and would advise MRI for further evaluation and characterization of this case.
What kind of orthogonal view are you want?
Sir, lateral views available so that it may
Of what?
demonstrate
Of
lateral view
what?
of this lumbosacral spine, so to see the presacral space involvement and
How
any
will that help you, a lateral view?
so there may be some extension of this mass in the presacral space displacing the rectum, or so maybe I can find
Okay,
some.
how will you like to confirm this?
Uh, sir, I
Which
will,
modality do you want to see now?
sir, MRI.
So the patient cannot have an MR because
Okay,
of
sir, then CT. Yes, sir. So CT scan with contrast.
what is the role of contrast?
So to see any enhancement pattern inside the
Will
aggressiveness of the tumor.
will bone lesions enhance on CT?
Uh, so if they have a soft tissue component, then they may show enhancement.
Okay, go for it. You've got the CT with you. Just
Okay, I'm provided.
go for the sacrum.
Okay. Uh, so I'm provided with CT scan axial slices of an 84-year-old adult patient, male patient, who has presented with. Okay, sir, I can
Give me
see
your
that.
diagnosis.
Sorry, sir.
Just conclude the case.
Okay, sir, I can see that there is a destructive lesion involving the left half of the sacrum, and it is causing cortical erosions and almost complete obliteration of the sacral foramina. Sir, I would like to see its extensions on the bone. Yes, on the bone window, so I can see that the lesion has a soft tissue component and it is extending slightly into the presacral space. The sacroiliac joint is intact on this visualized image. I cannot see any definite vascular invasion
Okay,
or
give me the
mass invasion.
diagnosis. Diagnosis.
Uh, so this is likely metastasis involving the left half
Okay,
of the
thank
sacrum.
you. Thank you. So the first case is benign lymphoepithelial hyperplasia of HIV. Uh, in benign lymphoepithelial hyperplasia of HIV, what you see is that you will see cysts in the parotid gland. And with that, there can be sometimes, rarely, cyst in the submandibular gland also. In our case, the cysts were also present in the submandibular gland. With that, you have to look for uh, lymphoid tissue hyperplasia. Look for adenoids, look for any, the palatine tonsil, the lingual tonsil, look for any lymph nodes. And then you make a diagnosis. It is not parotitis, these are just cysts. And number two is that it's a benign entity, there is no malignancy. Second thing is that in the differential diagnosis, which the candidate mentioned, Sjogren's, etc. In Sjogren's, the architecture of the parotid will be, abnormal. In this case, you will see better looking architecture, but the main finding is that you have to look for other bits. So, candidate two, you were two, isn't it? So you did okay, but there were a few things which you were, terminology, etc. You were confusing. You were not very clear what else to look for, and you should have been more proactive. And then there were lymph nodes, by the way, there. There is no role of diffusion weighted sequence. We don't usually do diffusions in neck. And you actually asked for it initially also. If there was some ring enhancement or things like that, you could have said that, if just to make a point that there is some infection or whatever. But it was simple case of lymph. This actually these pictures are from the case, and here we can see what we can see. What we can see is that on axial sequences there are multiple cysts in the both parotid gland. With that, immediately look for adenoid hyperplasia. In our case, there was submandibular gland, which also contains cyst. Actually, there are lymph nodes, this and this and this level 5 lymph nodes. I did not show you coronal, but having said that, one can develop or should develop eyes to pick up lymph nodes on axial sequence. So there are, though they might not be very large in size criteria, but they are quite numerous. So there are, and this is the post contrast where there was no enhancement. So this was benign lymphoepithelial. Please remember that all of these patients do not need to have AIDS. They can be just HIV positive and have this entity. Key concept is that these are benign. I think that the candidate got it right as far as that concept is concerned. Now, sacral metastasis. In sacral metastasis, uh, candidate did well, picked up the finding, but just to revise that, in rapid reporting also, we used to always teach that you have to, this arc-like sacral foramen, you have to visually see. Please remember that in many cases you cannot see because of gut gases, etc. So this was well picked up. But to ask for an orthogonal view of sacrum, I think I'll delete marks for that. There is absolutely no role of an orthogonal view of sacrum to pick up a lesion. Go for next modality if you want. So otherwise, the findings were fine. And then this concept of I will ask for CT with contrast, there is absolutely no role. What will contrast tell you? You know, you can make a diagnosis there and then without any contrast. So this was picked up very well. There was um, and of course on CT also it was picked up. Now, as far as the previous case, sorry, I think it is not projecting for you. So as far as this case is concerned, I showed initially, please remember the key sequences in neck imaging are STIR and T1. This is what we do. And then, of course, you can do coronals and sagittals, T2 sagittal also for the cord, etc., because that is visible. And then for contrast, you have to do fat saturation. Now, in this particular case, there are multiple cysts in both parotid gland. And then the key finding, which once you pick up, benign lymphoepithelial hyperplasia, look at this. This is adenoid. So you have to tell the examiner that do a running commentary that I'm looking for adenoid hyperplasia, and here I can see it. Then these are, the tonsils, the palatine tonsils, they are also prominent. The lingual tonsil is not very prominent. We can see it here, but these are cysts in the submandibular gland. So this is the submandibular gland, and up here is the parotid gland. And with that, if you see here, now look at this. This is lymph node, 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 node. All of these are nodes. And on a stir sequence, they are beautifully seen actually. All of these are nodes, level 5 node, level 1 nodes. Of course, I only showed a post contrast, which means nothing because the cysts do not enhance. And I did not show you a coronal, but just to make a point that on coronal, you can see, look at all of this, the ring of lymphoid tissue, everything is prominent. This is the submandibular, this is the parotid and the parotid. And look at these lymph nodes, how prominent they are, how many they are. So this was benign lymphoepithelial hyperplasia. Okay, thank you, candidate 2, and we go to candidate 3.
Thank you, sir.
Good evening, sir.
Good evening. So candidate 3, you have got a 66-year-old male, left upper cheek swelling. Over to you.
Sir, I'm not able to see the image.
Oh, you are not able to see. Just 1 second.
Yes, sir. Now it's visible.
Okay, please.
Okay. I've been presented with a frontal mandible X-ray of a 66-year-old male patient who's presented with bone swelling, cheek swelling. I can see there's an ill-defined area seen involving the uh, left angle of mandible, left angle of left hemimandible.
Can you ask for mouse? I want you to point it out to me.
Yes, sir.
The mouse is with you, please.
Yes, sir. I can see that there is an ill-defined area of, sir, it's out here.
No,
Ill-defined.
don't worry. Don't worry. That's just projectional. Don't worry about that.
Okay.
I'm not interested in mandible. Over to you.
Okay, sir.
So please remember that swelling is in left upper cheek.
Okay. I've been presented with a frontal X-ray of a mandible. I can see that there is an ill-defined opacity seen in the region of left maxillary sinus out here. Mm, I'm not able to visualize anything else.
So look at the upper alveolar process of the maxilla. Anything?
So there appears to be some erosions out here, sir, in the left.
Okay. What would you like to do next?
Sir, I would like to further evaluate this patient with an MRI
Okay.
or
In this
CT, in
till
CT.
CT. Okay. So till now, what are you
Yes.
worried about? What will be your differential on this OPG?
Sir, on this OPG, there appears to be an ill-defined lesion. There's no evidence of any white zone white zone. It appears to be an aggressive lesion. this needs to be informed, and a further evaluation with a CT would be required to look for the
What is
extent of
your
the lesion.
differential? What is your differential?
Sir, it could be because it is an aged patient. This could be a metastatic lesion, or it could be carcinoma maxilla.
Okay, just hold on, please. Just hold on.
I've been, sir, should I start?
Yes, please.
I've been presented with a coronal images of the CTPNS, paranasal sinuses. I can see that there is an, sir, I'm not able to scroll through the images.
Ask it again if you want, the mouse.
Yes, sir.
With you, please.
Yes, sir. I've been presented with, I'll just start from the first image. Okay. Sorry. It's just, I've been presented with coronal images, CT paranasal sinuses. I can see that there is there was an evidence of an ill-defined, fairly defined lesion seen involving the left maxilla, which was seen causing erosion of the alveolar process. It is also seen causing bony remodeling involving the uh, posterior wall of the maxilla. Sir, I would like to look at the axial images if available, the axial sections.
So tell me your opinion on this.
Sir, on the basis of this, it looks to be sir, it is causing bony expansion involving the medial and the lateral wall. So it could be a more benign process, but then simultaneously it is also causing destruction of the alveolar process. Sir, it could be, it is also seen,
Give me your diagnosis or differential.
uh, so it could be a neoplastic etiology involving the maxilla, or an odontogenic cyst, because the apex of it could be arising from the root of the teeth.
Is it arising from the root? Is it
Sir,
related to?
so it is related to the root of one of the tooth out here.
So you think it is a cyst? How can you differentiate it
Sir,
if
I
it
would
is?
like to measure the HU value of the lesion.
Yeah, HU value was not of cyst. Do you want to
Okay.
do anything else?
Uh, Sir, I would like to look at the post-contrast images if available.
Okay. Just leave the mouse for me, please.
Yes.
So this is I've given you an MR. This is a stir MR, and I am going to now give you a post contrast. This is a post contrast.
Sir, on stir images, I could see that the lesion was T2 stir hyper intense, and on post contrast images, it is showing heterogeneous enhancement with few non-enhancing areas within. It appears to be well defined superiorly, but has an ill-defined border inferiorly, which is likely due to probably because of the aggressive nature of the lesion. Uh, the differentials would be that of an aggressive lesion like a neoplastic etiology, or it could also be because of invasive fungal sinusitis resulting in destruction of the alveolar process.
So which kind of neoplasia?
Uh, so squamous cell carcinoma.
Okay, thank you. Over to you.
Yeah. I've been presented with the frontal pelvis with both hips radiograph. I can see that there is evidence of a metallic processes seen in the right hip joint. Uh, I'm trying to just visualize all the uh, just follow all the cortexes. Mm, uh, there appears to be some calcifications around the uh, right hip joint. Uh, some hyperdensities around some opacity is seen around the right hip joint, uh, which could be because of complications of the metallic processes. I'm just trying to look at the other bones to look for any other abnormality. Uh, the uh, I can trace the borders of the right iliac blade as well as the left iliac blade. I don't see any uh, obvious other abnormality. Uh, so I like to focus back on the right hip joint. So I can see that there is multiple opacities seen involving the on the lateral portion of the right uh, hip joint, which could be because of the complications of the right hip joint. Uh, so I'm not getting the name of that. Uh, I would like to inquire about the history of the patient if he's suffering from any uh, pain or
There is
any
pain.
okay if there is any difficulty in the range of movement. uh, mm, so this could be because of the wear and
What's
tear of
happening
the
here? What is happening here?
there also appears to be an ill-defined lesion with few uh, there also appears to be an ill-defined lesion in the soft tissue adjacent to the prosthesis with few chondrite matrix within, uh, few small calcifications within. Uh, I would like to know matlab, I would like to inquire about the history of the patient if this prosthesis was done, this surgery was done for removal of any other in any previous tumor. This could be a recurrence of the tumor. I would like to inform these findings
There is
and
no
further.
no history of any tumor, and this prosthesis is there since 22 years.
Okay. Um
Give me your final conclusion.
Uh, so these opacities appear to be because of the wear and tear of the metallic processes. I'm not able to remember the name of the disease, but this is probably because of the wear and tear uh, of the process of the material with extension of that material within the hip joint. Uh,
Okay, thank you. So now my feedback will be candidate three that you have to know your differential diagnosis. And in this case, there were many things which are my observations that yeah, it was obvious that your eyes are not developed to look for and the differential diagnosis of what we call um, lytic lesions in the maxilla or mandible. So this is a overview, bony lesions of mandible and maxilla. So they appear cystic, and but so for example, radicular cyst and nasopalatal duct cyst, dentary cyst, they are usually related to the tooth. They appear as cystic. Ameloblastoma can appear as cystic on a CT scan or let's say an OPG, but it is of course a solid tumor. And the key concept is that you have to do you did ask for Hounsfield, which was fine, but ultimately you did ask for contrast, which was fine. I showed you an MR, and you have to look for anything solid. Now, this was not as aggressive a lesion as, for example, you said squamous cell carcinoma. That will just destroy everything, that will not expand. So the ameloblastomas, they are locally aggressive and they will cause expansile lesions. Of course, there is a very rare type of ameloblastoma which can become malignant also. So now this is a ameloblastoma. This is in the mandible, which is more common than maxilla, causing expansion. On post contrast, you can see there is solid component on this CT. So this is ameloblastoma. This is a classical location, so bubble type of variance, but it will have solid component. And this is on MR where we can see. So this is a CT, and on MR, just like our case, our case had similar signal intensity, and on post contrast, it was like this. Now, second case is particle disease of the hip. Particle disease of the hip. What is it? Particle disease of the hip. Uh, it refers to an aggressive granulomatous periprosthetic osteolysis. Prosthetic osteolysis. And it can cause loosening, etc., and failure. Hip can be there, and shoulder, knee, phalangeal joint replacements can be involved. The theory behind it that there is aggressive granulomatous reaction to small particles of prosthetic component, for example, metal, cement, or polyethylene, breaking off from implant wear and tear, leading to osteolysis. Of course, it can happen within the joint cavity. Our case was happening outside. And what will happen is, look at this radiological features from Radiopedia. Evidence of progressive lytic focal regions around the replacement. So this one around the replacement means if it is in the joint cavity itself. Ours was outside the joint cavity. And there is usually smooth endosteal scalloping and no sclerotic reaction. So MR, in our case, I have not shown you MR. I have got an MR, I'll show you, but there was lot of artifact on that MR. When they say capsular thickening, they want to tell you that it is within the joint cavity and presence of low signal debris within the joint. Our case was not in the joint. So this is particular disease. Somebody has said, can it happen after 20 years? Yes, it can happen even more than that. So now, if you see here, you can actually see a bit, a few particles inside high density, and you can see this scalloping. So of course, we did not go for an MR. In this case, this is the MR, and actually this, there was a lot of artifact, right? Having said that, this particular thing is visible, and you can see some debris inside. So, and you can see how it is eroding it. So this is, I'm not saying, I think you have to develop your eyes to pick it up on a plain film when you see this kind of appearance. So this was a stir sequence. Now, Now, regarding your OPG, if you look carefully, because I did give you a hint that it is left upper cheek. Now look carefully that this is the normal cheek. I'm just talking about the alveolar process. Ultimately, you did pick it up, but this is a tooth, and do you see this?
Yes, sir.
And versus this, and you did pick it up ultimately, but you can see lucency here. So it was a difficult call on OPG, but it was there. Now, as far as this is concerned, you can see the same thing, and this is the concept of bony expansion. It's not destruction, metastasis, squamous cell carcinoma. They will not give any time for expansion. They will just destroy it. So, ameloblastoma, by definition, is a locally aggressive benign lesion. Please remember, 2, 3% or 4%, they can convert to malignant version also, but that is rare. And then on MR, we can see this is the post contrast. I had initially shown you this one, where you can see high signal, and then of course we went through the post contrast, which is this one. It enhances, it has got solid components. So the key point is that if you do not know your differential from your book, you will struggle. So you must revise your differential. And in head and neck, once you know your differential, it becomes very easy. Then you describe it, and don't do this will be a blunder. If you tell me on this case that, squamous cell carcinoma or metastasis, because of the pattern it is. Okay, thank you very much, candidate 3. Candidate 4, thank you.
Yes, sir. Good evening, sir.
Good evening, candidate 4. I am going to show you a CT scan. This is a 54-year-old female, acutely unwell, frank hematuria. Over to you.
Okay, sir. So requested remote control.
I have given it to you.
Yes, sir. Yes, sir. So here I'm provided with eggshell post-contrast CT images of a so 40 years female, I think 50 years female.
42 female.
Okay, 40 years female who has presented with frank hematuria. I'll just quickly go through the entire stack of images. I'm so sorry, so the images are moving very fast. Okay, so I'll just quickly go to the last cut of images before giving my final comments. Okay, the patient has presented with hematuria, and I would quickly come back to the site of interest. I can see that in the I can see that there are subcapsular collections noted in the bilateral kidneys, along the bilateral kidneys, and okay, these are hyperdense subcapsular hyperdense collection. However, in my routine practice, I would like to see the non-contrast images to confirm this. And yes, I can also see that there is some also cortical breach noted as well along the one of the renal cortex, and these are bilateral regions. Apart from this, okay, there is also mild right-sided pleural effusion noted as well. And I will just quickly go. Yes, I can see that there is some perinephric fat stranding noted. And okay. And yes, rest of the visualized abdomen appears normal. So in a female patient who is presenting with hematuria, these collections are most likely perinephric hematoma as a complication of vasculitis. Most likely it could be, I think this is polyarthritis, I think polyarthritis nodosa. Uh, or yes, sir, I think this is most likely as a complication of vasculitis. The patient has developed these perirenal hematoma. If the patient had any history of trauma, then this could be post-traumatic as well, but this is very unlikely since they are bilateral, and it could be also because of some any hemorrhagic neoplasm, but again unlikely as I'm not able to see any focal lesion in the bilateral kidneys. Lymphoma can also give rise to this appearance, but they are more enhancing, and I'm not able to see. They are not subcapsular, and I'm not able to see any lymphadenopathy. So to sum up, in this patient who is presented with hematuria, my topmost differential would be perinephric collection due to the vasculitis affecting the kidneys, most likely polyarthritis nodosa. I would convey my finding to the referring physician about the vasculitis as the most common cause, and I would. I would like to correlate this with the I think P Anka levels can be done for this, and
So,
I would like to.
so what will you like to do next? How will you confirm your diagnosis?
So I would like to see the angiography images if available for this patient, or I would proceed with the conventional angiography for confirmation of my findings. Okay, so here I'm provided with the
You can
selective.
ask for mouse, you can scroll through because they are serial images, I believe.
Yes, sir.
Can you scroll and it will change?
Okay, so I'm not getting the option of.
Okay, let
I think I'm still having the control of the screen. Yes, I'm still having the control. Yes, sir. So here I'm provided with selective angiogram of left renal artery, in which I can see that the contrast is seen in the left main renal artery and also in the segmental branches, and I can see that there are outpouchings, nodular outpouchings, contrast-filled outpouchings noted involving the segmental vessel. This is in keeping with my
where is the
finding.
outpouching?
These are the outpouchings, contrast-filled outpouchings.
Where where are you pointing out to something?
Yes, sir. I'm using my mouse to point it out. If you could see, sir. So here,
Okay, yeah, I can
yes, sir.
see your mouse.
These are the contrast-filled outpouchings,
So
which
which
I can.
artery is this? Which branch is this? This is a segmental branch?
I think so. These are the subsegmental branches. And these are
Where is
the.
it? Can you scroll through it?
Yes, sir.
So just one
Yes.
second, you've gone to the right actually. So I am going to take you back to the left. So this is the left and just go slowly. It is a image after image after image.
Yes, sir. So here. So
Mhm.
these are the outpouchings, and I can see the contrast blush as well. So these can represent microhemorrhages. So I think that the patient is either this confirms my findings of polyarthritis.
Why does microhemorrhage happen? What happens?
So the patient has vasculitis, and so the patient, the vessels are very much friable. So that can cause microhemorrhages, which has led to the perirenal hematomas in bilateral kidneys.
Before development
Perinephric.
of you see you mentioned some outpouchings. What do you call them? What are these?
These are the microaneurysms, sir.
Okay, thank you.
Yes, sir.
Over to you. This is a young 11-year-old swelling knee.
Okay, sir. So here I'm provided with the frontal radiograph of left knee of 11 years old patient who has presented with some knee swelling. Okay, so I will just quickly have a look at the entire radiograph before giving my final comments. Okay, sir. I'm just trying to trace the cortex and. Okay, I'm just tracing the cortex of the femur, the tibia, and the fibula. I think so that the patient is having some swelling on the medial aspect of the distal femur, which I would like to confirm from the history or if some physical examination where the swelling was, I could see that there is some swelling noted on the medial aspect of the distal femur, and I could see some calcific foci as well inside it. And apart from this, I'm not able to see any bony abnormality. The cortex appears normal. I'm not able to see any lytic sclerotic focus in the region of femur or in the tibia. Also, I could see that there is a lucency noted in the proximal diaphysis of the left fibula. In my routine practice, I would like to have a look on the orthogonal images provided to me.
Okay, just 1 second. Here you are.
Okay, so on these orthogonal images, again, I can see that there is a lytic lesion noted in the proximal diaphysis of the left fibula with the wide zone of transition. However, the overlying cortex does not appears to be breached, and there is no obvious periostal reaction noted. I'm not able to see any matrix mineralization, uh, and yes, and rest of the visualized bones appears to be normal, sir. If, may I have a look at the AP and the lateral radiographs side by side? If Okay, so again on this, I can see that the lesion in the fibula appears to be lucent. There's a lucent lesion with wide zone of transition, and the overlying cortex appears to be, there's no cortical discontinuity seen. There are no periostal reactions seen. So this looks like, considering the wide zone of transition, I think that this is a aggressive looking lesion. I would like to know from the history of the patient if the patient is having any history of fever.
So
This
the point is that I am not at all interested in this.
Okay,
Why
sir.
is there knee swelling?
Yes, sir. So the knee swelling, sir, I can see it, sir, which I noted earlier, was a soft tissue swelling on the medial aspect of the left distal femur with some calcific foci noted inside it. So it could represent some neurocysticercosis could be a possibility in this case, considering the appearance. It could also be a hemangioma with with phlebolytics, which can give rise to this appearance. So I would like to proceed with the MRI images or any ultrasound images available for this patient for confirmation of my diagnosis. So here I'm provided with the uh, so can I okay, yes. So the
Can you
images are
scroll?
not so the
Can you
images are
scroll?
no, sir, I'm not able to. Yes, now they are scrolling. Yes, sir. So these are the eggshell stir images of
I
this
am
patient.
scrolling. Can you scroll, or otherwise I will scroll for you?
So if you can scroll, that would be better, sir. Somehow I'm not able to control right now. So, okay, so here I'm provided with the eggshell stir images of this patient, which again re-demonstrate a presence of a altered
What is your
signaling.
conclusion? Just give me your conclusion.
So I'm thinking in terms of some aggressive neoplasm from the soft tissue of this patient on the muscles could be a sir, soft tissue sarcoma is a possibility, or could be hemangioma as.
Okay, thank you.
Yes, sir.
Now, did you get two or okay? Yeah, you have already got two, isn't it? Yeah.
Yes, sir. I've done 2 cases, sir. Thank
Yeah.
you.
Okay. Thank you. Polyarthritis nodosa. Now, polyarthritis nodosa is a systemic inflammatory necrotizing vasculitis which involves small to medium size arteries. So please remember they're small to medium size arteries, fifth to seventh decade. So, and then Uh, it can cause symptoms according to involvement of the organ. Kidney is most commonly involved, 80 to 90%. It can cause many things like, hemorrhage, hypertension, death, of course, infarcts, etc. There can be other manifestation. For your exam, GIT is extremely important because it can involve GIT, and for the exam, that is most important. Now, what happens is that there is transmural necrotizing inflammation. What then happens? Once there is necrotizing inflammation, then there is weakening of the wall leading to microaneurysm and subsequent focal rupture. So that is the pathogenesis. First of all, inflammation, necrotizing, then microaneurysm, and then rupture. So this is what happens. Please remember the arteries involved are interlobal. So go back to the anatomy. This is renal artery. This is segmental artery. Then is interlobar, and then is arcuate. So arcuate and interlobar. Uh, can you see my screen?
Yes, sir. It is visible, sir.
Okay. So they are uh, you these are involved and segmentals are not involved. So CTA can be done on a normal CT, just like I showed you. It's difficult, but I'll come back to the CT when I describe it. And DSA can be done. You will see microaneurysms, and then you will, of course, you can see bleeds, etc. It will be fatal if it is left untreated, and usually corticosteroids or cyclophosphamide, etc., is done. Then was a case of intramuscular hemangioma. So, the terminology is very confusing, and even now, literature uses old terminology, and there have been classification international classifications. Basic concept is what? The basic concept is that in intramuscular hemangioma, usually you will see it in young adults and adolescent. There can be large, thick walled veins. There can be cavernous vascular spaces. These will be larger spaces than just the vein. There can be capillaries, there can be lymphatic, and there can be mature adipose tissue. Uh, and they are usually slow growing, painless mass. Where can it happen? It can happen, most common is lower limb, thigh, calf, head and neck, upper limb, and trunk. Now, this is a case from our teaching files, which was very interesting. If you look carefully, look at this fibula, and you can see as if there is a permeative bony destruction here. And if you report it in a young patient of 14 years old, you will report that this is, aggressive lesion. So most probably either Ewing's or, sometimes even in diaphysis, rarely osteosarcomas can happen. Of course, infections in the differential. But what is the key? Key is the phlebolytics. And phlebolytics are extremely important. Even here, there were phlebolytics. This phlebolith, 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 phlebolith. So phlebolytics look for phlebolytics. And what happens is that this is a stir sequence. This is a T1. This is a post contrast T1 with fat saturation. So on stir sequence, you can see these, thick vessels, and there can be fluid levels also in the bigger ones. When you check for a T1 weighted sequence, you can see that there can be high signal, there will be enhancement. Look carefully at the fibula. So this is the fibula, and you can see that how it is sort of infiltrating. So it's a benign entity, but it can do that. It is infiltrating into the fibula. there is a low role of Doppler, and that is an exam question because on Doppler, when you do Doppler, there will be compressibility. These vessels will compress, and that is how you differentiate it with any sarcoma, etc. Other examples of phleboliths or soft tissue hemangioma. This is a 7-year-old. So let's go through the cases. Now, in this case, this was nothing. So candidate, you are candidate 4, isn't it?
Yes, sir.
So the point is that you got, you just went on and on this. I was not at all interested. It was, by the wide zone of transition because on the lateral the radiographers have marked it, so you got sidetracked. Now, uh, this is not at all a wide zone of transition. This is a, don't touch me lesion, as in a fibrous cortical defect. It is of no significance. So now you did pick up the finding, but even in your final conclusion, when you say that it can be a sarcoma versus a hemangioma, it's a big, you cannot get through that case. And this is what they are checking. So, for example, I give you a totally different example. If there is a simple bone cyst and you report it like this, that there is a simple bone cyst, however, malignancy cannot be ruled out, and ask for, bone tumor center. That is the type of thing they are checking in FRCR. So please remember, in radiology, there is a black and white world and there is a gray world. So a safe radiologist knows the difference. Having said that, when there is a black and white world, when you can make a diagnosis, your confidence is what they are looking for. So this, in this case, these are phleboliths. Look at the age, look at this soft tissue swelling, which you had picked up. And of course, these phleboliths you had picked up. Now, I just gave you, because of the time factor, one stir sequence which can see these vessels. Even here, if you see here, these are all vessels. These are,
But the screen is not visible, so sorry.
okay, thank you for letting me know. So when I was showing you
The X-ray was
the
visible, but
plane,
not the
okay,
MRI.
now it is not visible. Okay, let me. So
Visible.
this is the one which, if you look carefully, you can see that all of these are vessels. They are in the medial vastus medialis muscle, and of course, I could have shown you more, but because you gave me the differential of a sarcoma, uh, that was, I think, now this is a post contrast where you can see these vessels, and of course I can show you a coronal, this one, and this is a post contrast. This is a post contrast. So you cannot call it as a sarcoma in the differential. It's a black and white case. Okay, thank you very much, candidate 4. So candidate 5, are you with us?
Yes, sir, I'm very much. Good
Okay,
evening.
good evening. So candidate 5, let me show you case. What happened was that this case uh, presented with incidental gross hydronephrosis on left side. The patient is 62 years old, and on ultrasound, which was done by the for some other clinical reason, gross hydronephrosis was picked up on the left side, and we have done a CT urogram. Over to you. Ask for mouse, please.
Yes, sir. request done.
Okay, with you.
So the images are jumping actually. So grossly, I think that there is gross hardening process on the left side. Um, the cortical enhancement is also suboptimal, and because this is a urogram, right kidney has shown excretion of the contrast, but there is no contrast excretion on the left side yet. Uh, I see that there is some tortuosity of the upper ureter. Uh, and also there is cortical thinning on the left side. I'm trying to trace the ureter. Yeah, so the ureter also appears to be dilated. So it's not a pelvic-ureteric junction obstruction or something like that. But there are multiple outpouchings that I note that are rising from the ureter. Uh, and okay, the distal ureter appears to be narrowed, or we can say that this is a normal part of the ureter. Uh, I'd like to see up to the prostate. The prostate is enlarged and well defined, most likely a benign enlargement of prostate. Um, so I think these are ureteral, this is ureteral pseudodiverticulosis uh, with multiple outpouchings arising from the ureter.
Pseudo, what did you say?
Pseudodiverticulosis.
Of the ureter.
Uh, yes, sir. Because I think these cystic outpouchings are in the wall of the ureter, I suppose.
Where is it?
So these one, this.
Trace them, trace it.
Okay, yeah. So this could be a tortuous part of the pelvic junction as well. But I saw this thing in the lower part as well, like here
Please
in this.
keep tracing it. Keep tracing the ureter.
Yeah, there. Okay. So in the lower part of the ureter, I see some soft tissue density is noted in the lumen of the ureter, which is enhancing on the post-contrast images. Okay. So the outpouchings I was seeing, I think they are the basically tortuous part of the ureter only. And there is a growth or a mass in the lower part of the ureter, uh, which could be like transitional cell carcinoma, uh, and which is causing this dilated ureter and the Hartner process on the left side with delayed excretion of contrast. So,
Do you think it's a
in my
long-standing
routine,
process?
sorry,
Do you think it is a long-standing process or?
uh, yeah. So this could be a long-standing process um,
So
because
the transitional cell carcinoma was sitting there for a while?
so yeah, it might have grown over time, and this led to this hydronephrosis and hydroretor with cortical thinning because cortical thinning is there. That's why I'm thinking that it's a long-term process. Like,
So you said it is enhancing. Can it be high density? How can you confirm that?
yeah, it can be high density also. Yeah, I'll have to look at the plane sections. If this is high density, then this could be a blood clot as well. But that won't be this long standing, I think.
Hmm. So will
So in my
transitional
routine practice, yeah.
Yeah, in
In
your
my routine
routine
practice,
practice,
I'll do the delayed scans to see if there is an excretion of contrast in the pelvic
this
vessel system or the
this
ureter.
is a delayed scan.
Okay,
You,
okay.
yeah.
So the kidney function is affected, like excretion of the contrast is not seen on the affected side. So, and this can be a long-standing, no, basically, this can be a long-standing process also.
How can you explain that?
So because there is cortical thinning and renal function is affected.
What I mean is that
Yeah.
long-standing process like what? You have said transitional cell carcinoma.
Yeah.
So, but
Okay. Yeah. So
what
transitional
else?
cell carcinoma is one differential. There could be other differentials also, like any infective or inflammatory pathology of the distal ureter.
So,
Okay.
are there any stigmata to confirm that?
Um, Sir, I think we can do a urine test routine for any bacterial infections or any for urine test for AFB can also be done. Um, and like I think um, a cystoscopy can be done in this case also.
The word cystoscopy means
Cystoscopy with ureteroscopy.
Mm.
So these are MRI sections. Okay.
Yeah.
So I'm not able to scroll. So I'm not able to scroll actually.
Can you ask the mouse once again?
Yeah.
Yeah.
Still not able to do it.
So I'll do
So
it
can you
for you.
scroll for me? Yeah. So these are axial sections MRI, T2 weighted images, in which I see that the left ureter is dilated. Yeah. Okay, so is there a mass here in the right lumbar region?
Don't worry about that. Just
Okay,
look at
that's
the left
foul. Yeah.
urine.
Okay.
Okay, so give me the final conclusion.
So this is basically like grade 4 hydronephrosis of the left kidney with cortical thinning, with tortuous and dilated ureter. Okay, with some isointense to hyperintense signal intensity noted in the distal part of the ureter, filling the lumen completely, blocking the ureter, and uh, leading to obstructive uropathy on the left side. Um, to take things further, like we can do a urine routine to rule out any infections and to look for any RBCs. And we can also advise cystoscopy with ureteroscopy to see if
What
we
is
are able.
your conclusion as in pathology
Okay.
wise? What is this?
So I think this could be a transitional cell carcinoma of the distal ureter.
Okay, thank you.
Okay.
This patient presented with 51-year-old male, right cheek swelling and pain.
Okay. So requesting control again.
Approved.
So I'm not able to scroll. Can you scroll for me?
Yeah.
Okay. Okay, so I see there's a cystic swelling in the right side of the cheek, just below the masseter muscle, and it is oblong in shape, and it is extending towards the floor of the mouth on the right side. Uh, yeah, inside, like just on the inner margin of the mandible. Uh, it's reaching inferiorly, it's reaching up to the submandibular region on the right side. Uh, yes, so and this there are no septations noted within the lesion. I think it's a benign cystic lesion uh, in the floor of the mouth and right submandibular region. Uh, I don't see any other lesions in the neck. I don't see any lymph nodes in the neck. Uh, okay, so I think this is a marker they have put on the right side. Um, yeah, this one. So the parotid gland appears to be normal, and the submandibular gland otherwise also appears to be normal. Okay, so either this could be a branchial cleft cyst, um, second branchial cleft cyst, or um, it could be a ranula. Okay, so submandibular gland duct also opens in the same location. Uh, so this could be yes, yeah. Now I can see that at the distal end of the submandibular gland duct there is a calculus line there in the floor of the mouth. So this is basically dilated submandibular duct with I think cystocele or a mucocele type condition of the submandibular gland duct. But I don't see any like inflammatory
Give me
changes in the submandibular gland.
conclusion.
Conclusion is, sir, it is like cystic dilatation of the submandibular gland duct with the calculus at its distal end in the
So
floor of
this
the
is not
mouth.
a calculus. Let me tell you that this is not a calculus.
Okay.
You can ask for any other sequences also.
Yes, sir. I would like to see if any post contrast images are there, or if any.
Post contrast.
Okay, so in post contrast image. So there is a septa seen within the this cystic lesion. Um, and
Conclude it. Just give me the final diagnosis.
Sir, I think this is basically a benign cystic lesion in the submandibular gland region. Uh, uh, Either uh, this could be a plunging ranula, or it could be a second branchial cleft cyst.
Okay, thank you. Now, the Eurogram study was, I'll go through the case once I describe it on Cyrex. This was a long-standing entity. There was hydronephrosis. There was what we call obstructive atrophy of the left kidney. And the discussion point is that what is it? Now, first of all, it's a in the exam, you can never, and this is a very important point, when you say that enhancement, you must say that I want to see a non-enhanced to check for enhancement. And the same thing will happen in gut, for example, in bleeds, etc., or aorta, etc. You have to ask for a non-enhanced. Without that, you cannot say that it is enhancing. Uh, Number two is that as we proceeded on this, uh, you have to develop your eyes to look at the ureter, at the wall of the ureter. Is it thickened? Is there some soft tissue, intramural thickening, what we call, or is it something which is intraluminal? Something in the lumen which is long standing, and that is why it has caused obstructive uropathy. It must be sitting there for years. And this is a benign tumor. So these discussion points, I am not at all penalizing you that you did not say, but your thought process is what I'm talking about. Transitional cell carcinomas do not behave like this. Till now, they would have gone right and left. They would have gone outside the ureter. They would have caused many things else. So this is a benign tumor. So the ureteric tumors can be benign and they can be malignant. The most common, of course, malignancy is, of course, more common. Uh, Previously, we used to call it TCC and transitional cell carcinoma. Now we call it urothelial carcinoma, urothelial carcinoma. And there can be a urothelial carcinoma is the most common carcinoma of the ureter and the pelvic calyceal system. Please remember that if you pick that up in the exam, you must look for multiple. So that is a classical exam case because they can happen multiple on the same side, and also look at the contralateral because there is a percentage in which contralateral are there. But this case was because of the radiological features, go into this benign tumors. Now, so these are the benign tumors. Fibroepithelial polyp, which is most frequent benign urethral tumors originating from connective tissue. They are typically smooth, elongated, and cylindrical lesion that can cause obstruction. So they grow inside. And there is a pattern known as corkscrew pattern. At times you see that. And these one are other benign tumors. And so various modalities, CT, urogram, sometimes corkscrew pattern is there. Now, your case 10 was a plunging ranula, but the way you tackled it, uh, uh, you are not going to pass in this case. And because your thought process was, you know, was not structured, and you did many mistakes there. So even if you give me the final diagnosis of plunging ranula versus what we call second branchial cleft cyst, this particular case you are not going to get over the line. Now, submandibular cystic spaces, I'm going to repeat them, are a very, very important exam case. Diving ranula or plunging ranula, this is what our case was, versus second branchial cleft cyst, then submandibular abscess, then necrotic lymph node, and lymphangioma, dermoid, epidermoid. All of these are very important. Now, if you look at the anatomy, a repetition of the anatomy, that this is the floor of the mouth, and this is the sublingual gland, and this is the submandibular gland. This is the submandibular duct. Now, in our case, the submandibular gland was absolutely pristine. So whatever you were seeing on the scan was not the duct where you confused as if there is a stone. That is a total different finding where you will see a stone in the duct, and then there will be sialactasis where there will be ductal dilatation of the submandibular gland. In our case, there was nothing like that. So uh, this is the sublingual space, and this is the submandibular space. This is a ranula. So what is a ranula, pathologically speaking? Ranula is a retention cyst of the sublingual gland, which sits in the floor of the mouth. There is a retention cyst which sits here. Till the time it sits here, we call it a simple ranula. If it goes down, if basically what happens is that it bursts and it goes down in the submandibular space. Sometimes there might also be a hole in the mylohyoid through which it goes down. So once it goes down, we call it a plunging ranula or a diving ranula. So this is a case of ranula, which is not plunging, it's a simple one. This is a plunging ranula, and there is a sign which was visible in our case, which is we call it the tail sign. That it has got a tail because part of the retention cyst it's still sitting in the sublingual space. It gives you this kind of a tail appearance, and part of it is sitting down here. So this is a diagram, and this is another case in which it has gone down, and another one. Now, second branchial cleft cyst, and this is what you told me in your differential diagnosis. So, second branchial cleft cyst, classical location, and this is the classical location. This is the submandibular gland, this is the sternocleidomastoid muscle, and the second branchial cleft cyst will be sitting in between the two structures. In our case, that was not the case. You see, this is an second branchial cleft cyst where it is sitting in between. So this is the submandibular gland, this is the sternocleidomastoid muscle. Location is the key, and this is infected because it shows enhancement. This is a case where there was a lesion, a cystic lesion on ultrasound. So on ultrasound reported as possible branchial cleft cyst. On MR, what is happening is that these are necrotic lymph nodes. These are necrotic lymph nodes, and beware of that. If there is necrosis because these lymph nodes means these are malignant lymph nodes. So let me go back and go through the cases. Now, first of all, this ranula case, here we can see, look at the anatomy. We can see now this is the tongue and the oral cavity. This is the mandible. You can see this tail. This is the tail sign. And please remember that nothing is happening to the submandibular gland. This is the submandibular gland. If there was a stone there and if this was the duct, then there would have been sialactasis in this. So this thing is sitting anterior to the submandibular gland. On the other hand, uh, the if it was a branchial cleft cyst, it would have sat behind it. This is the sternocleidomastoid muscle, so it would have sat here. And this particular plunging ranula shows a bit of enhancement. It was actually mildly infected. And I told you in the clinical that the patient has got swelling as well as pain. And pain was, I did not show you a coronal, but just to make out, there was a bit of enhancement. So it became infected. That was secondary infection. Now, as far as your second case is concerned, which is urogram. Now, first of all, go back to the basics. Look at this kidney. Now, kidney parenchyma is atrophic. Look at the cortical thickening, and it is still enhancing, means it is not completely dysfunctional, but there is gross hydronephrosis. So this is all tortuous ureter, and as we go distally, you can see this. And this is where you mentioned that it is enhancing. So you should have asked, by the way, it is enhancing, but the only thing is that you should have asked for a non-contrast, or you had said that in my normal practice, I will compare it with non-enhanced. I believe that it is just to confirm that this is enhancement. Because the other differential diagnosis, as in hematoma, etc., in a that will also you have to rule out. But develop your eyes to look at the wall of the ureter. Now, this is the wall, and it is imperceptible. It is thin wall. So look here, even here, look at the wall, look at the wall. Even here, look at the wall. Whatever it is in the lumen. It is not in the wall. So infections, etc., can cause a lot of stranding, etc. Of course, there was no fat stranding, so there were no signs of infection. Basically, and of course, now just 1 second. So this was the T2 which I showed you, and you can see slightly different signal intensity, slightly hypoequic. So this was actually a benign mass, but I was just trying to see your thought process, that how can we explain, this is a post contrast, and on which again you can see this lesion here. So and the fine touch of it, the ureteric wall, is there any stranding? Why is there this gross hydronephrosis? Okay, thank you very much.
Thank you,
Candidate,
sir.
last candidate.
Yes, sir, I'm here.
Last candidate. Let me see what I've got for you. Okay, this is a 39-year-old male, knee swelling and pain. Over to you.
I'm presented with the lateral projection right knee radiograph. And in this radiograph, the striking abnormality which I can see is that there are multiple scattered foci of calcification which are noted anterior to the patella. And there is also associated soft tissue swelling in this area. I'm looking to see for any fracture. On this view, I cannot identify any fracture. Um, I want to see that is there any subluxation of the patella, superior or inferior, which for that I would like to measure the distance. But on the current study, it looks at its normal position. I would also like to see the AP view. And other than this, I can see that the femur and the
So
tibia.
just 1 second. This is the AP view, and just have a quick look, and I'll go back to the lateral.
Okay, I can see that the patella is at its normal position, and I can see that there is a focal lucency noted in the head of the fibula on this view, and
Don't worry about
uh,
that. Don't worry. That's just projectional.
okay, the joint spaces are normal. Okay,
Mm.
so on the lateral view, this is the abnormality, which is calcification within the soft tissues in the prepatellar area. So this looks like a young patient, and I would like to ask about any history of previous trauma. If there is no history of trauma, then this can represent uh, uh, bursitis in this area. The calcifications in this area are, however, representing that this might be a long-standing etiology. And I would also like to see that is there any related tendinopathy which might be the cause in this patient. I can see that the calcifications which are noted in this area are just centered in the prepatellar area and are not in the superior or inferior aspect of the soft tissues of the knee joint. So I can see that the calcifications are quite variable in shape, and a few of them also demonstrating internal foci of low density. And okay, the density of these foci, although are not comparable with the bone, uh, but uh, but this can be within the tendon also, or within the soft tissues. I'm thinking that.
So give me a conclusion for this. What this calcification? I'm interested in the calcification.
Sir, these calcifications noted in the prepatellar area within the soft tissues with no adjacent cortical lesion noted in the patella. I'm thinking that this is a long-standing etiology, maybe a chronic inflammation such as bursitis, and or
Why
it can also
why
be
will bursitis? Which kind of bursa is here?
the prepatellar.
So why will there be calcification in bursitis?
Um, Sir, if if it is long standing and it has a variable like secretions, it may calcify. If there is a chronic infection and it is long standing, then it may calcify later on.
Okay, thank you. Last case of the day. Now, this case is a 62-year-old male, has got
Okay.
vague abdominal symptoms, some element of, clinically speaking, distension, etc. The patient came to A&E. They just did a CT for further evaluation.
Request for control.
Yeah, please ask. So this is the last case of the day.
Okay. I'm presented with the photovenous phase CT abdomen, and I would like to start it from the first slice. Then I would go to the last, and then I would summarize my findings. So there is no effusion at lung basis. There is aortic some calcific changes are noted. The abdomen, I can see that liver shows normal enhancement.
Candidate 6, your voice actually is breaking up.
Okay. Sir, is it clear now?
It is now very clear.
Okay, okay. So the liver is showing normal enhancement. I can see a small hypodensity in the left lobe, which most likely represent a cyst. Uh, the gallbladder is, I cannot see any radiopaque calculus in the gallbladder. Okay. It is not, okay. The spleen appears normal. The stomach, okay, the stomach is non-distended. Sir, it is scrolling very, very slow. It's taking little bit time.
You want me to scroll for you?
No, sir, I can try myself.
Yeah.
Thank you. Okay. Pancreas is showing normal enhancement. Both adrenal glands appear normal. Okay.
So keeping in view the findings of the history of the patient is having abdominal symptoms. So I am trying to look for any pneumoperitoneum in this case. First of all, okay. In my routine practice, I would like to change the window, but okay.
Let me give you, yeah, here you are.
So I can see that there is a focus of gas which is noted around the liver. It is under the diaphragm, so this is in keeping with the pneumoperitoneum. I would like to see the source of this. For that, I would like to, okay, I can also see that there is some gas noted in the anterior upper abdomen as well. And there are small foci of gas, but they are noted within the bowel loops. And so I can see that there are multiple small lucencies noted within the large gut. I would like to trace the bowel loops. Okay, this likely represents the colon, transverse colon. You can also see that these lucencies are noted in the right-sided colon as well, yeah, in the cecum. And the rest of the large bowel is distended with the fecal matter. I can also see some gas in the wall of the bowel, so this can represent nematosis intestinalis. However, looking at the lucencies within the bowel loops, there are large cystic-like areas within the bowel. So I'm thinking that this may represent nematosis coli as well in this patient. And I am trying to see the cause of the pneumoperitoneum, although can you change the window to the soft tissue? Scrolling very slow. I want to go to the end of the slice, but it's not moving.
Okay,
So can you scroll?
Yeah.
Okay, so in the pelvis, I can see that there is there is some calcific foci in the prostate gland. Other than that, okay, the urinary bladder is shows no intraluminal lesion, and the sigmoid colon shows multiple outpouchings in keeping with diverticulosis. I'm looking for any free gas around these diverticula or fat stranding, which I cannot see that there is any fat stranding around any of these diverticula. I am looking for any mental infarct or epiploic
Okay,
appendicitis.
so what is your conclusion?
Sir, keeping in view these imaging findings, I'm thinking that the patient is having pneumoperitoneum likely secondary to the rupture uh, of the cystic lucencies noted in the sigmoid colon and the ascending colon. So, and also I can see that there is nematosis intestinalis in this patient. And these are usually benign. This is a nematosis coli, which is usually a benign etiology, but if ruptured, it can cause air within the bowel wall and can also cause pneumoperitoneum. So I would like to convey my findings to the referring physician. I could not establish any frank bowel perforation in this case. And further, I would like to uh, further, I would like to see any other views available to check any bowel pathology which might be causing this. Other than that, I could not identify any other thing in this CT scan. I would also like to ask about the condition of patient. If the patient is not sick, that much sick, then most likely this is the only problem he's having. So,
So what are you going to advise?
sir,
Pneumoperitoneum. There is pneumoperitoneum.
yes, sir, there is pneumoperitoneum, but as we couldn't identify any surgery-related cause, so I would just convey the findings to the referring physician and keep the patient under follow-up, and I would advise the decompression, like to insert the nasogastric tube or nil per oral to not to avoid the septic conditions in this patient.
Why?
Because couldn't identify any intestinal obstruction. Uh, there was no.
The surgeon asks you, should we go
Yes,
for a laparotomy?
that there is no cause to undergo laparotomy in this case because it is a benign finding and it can cause pneumoperitoneum in patients.
Okay,
So
thank you. Thank you. So the first case was basically, as the candidate pointed out, the anatomy is that in front of the patella is pre-patellar bursa. This case was extra-articular synovial chondromatosis. Key point to remember is that the synovium, the bursa, they are also lined by the synovium. That is the key point. And though it is extra-articular. So just like synovial chondromatosis can happen within the joint, as in this case, uh, or in this case around the elbow and the knee here, it can also, anatomy is the key thing, and the concept, this is from Radiopedia, another case, extra-articular synovial chondromatosis. It was a simple case, but the concepts of anatomy, the concepts of pathophysiology, this is what this case was about. Now, second case, you actually got everything, but uh, even in the end, I think you gave me the correct answers, but your confidence level was not there. And this is what I was checking. So the it was nematosis coli, and we also call it nematosis intestinalis, cystoides and intestinalis, small bowel, and nematosis coli with pneumoperitoneum. This kind of pneumoperitoneum is what we call pneumoperitoneum without peritonitis. Please remember, in medical school, we teach our students treat the patient, not the X-ray. And there are many examples in radiology where findings might be there, which have got, you don't treat them. So, for example, in on a chest X-ray, very simple example, pneumonia actually takes much more time to resolve radiologically than clinically. So if you start continuing antibiotics just on the basis of radiology, then you might end up giving antibiotics for a few extra weeks. So similarly, this concept is very important. So in nematosis intestinalis, gas in the bowel wall, differential diagnosis depends on the clinical state of the patient. Now, candidate 6, I told you, when an examiner is giving you the clinical history, it is very important to listen very carefully. And the clinical history was vague abdominal pain and abdominal distension. So, of course, you can again confirm it, but having said that, I had already given you that it is vague abdominal pain type of history. It was not very malignant history. Now, so it all depends. Nematosis intestinalis, when there is a gas in the wall, can depends on clinical state. If the clinical state is unwell patient versus well patient. And there are so many things in which you can see gas there, sort of incidental. Here, this case was about idiopathic. Uh, and I think the Americans call it primary nematosis intestinalis. Idiopathic is where nematosis cystoides intestinalis usually involves the colon, cluster of gas-filled intramural cyst. It is idiopathic. We don't know the cause. Please remember that in things like obstruction, gas can be seen in the wall of the bowel without it being, significance of necrosis or anything like that. Because the idea is that what happens in when there is intestinal obstruction or pyloric stenosis, that the intraluminal pressure increases, and suppose there is a nick or the rent at the mucosa, gas can simply go in, and from there it will track along the wall, and it can actually end up even in the portal vein. And I've seen cases where there was frank air in the portal vein, and the patient actually walked in the hospital because of this factor. Now, this is a potential plain film which can be asked. You have to know that it will give you a bunch of gray type of appearance. These are gas bubbles within the wall of, and on a barium examination, if you look carefully, if you look these ones, for example, end-faced, you can see side on that gas is, sort of bubbling out of the wall. And this is another example where the ascending colon till the splenic flexure is involved, and this is a barium examination. So from here comes this concept of causes of pneumoperitoneum without peritonitis. And this is the concept of treating the patient, not the X-ray. So there are many things which can happen in which there can be pneumoperitoneum without peritonitis, benign. And there is a list here, and thoracic causes, abdominal causes, nematosis cystoides intestinalis is one of them. There are some other, and there are female pelvic causes, even instrumentation like hysterosalpingogram, etc., etc. So this concept is very important to remember. So let's go back to the cases. So this is, once you know the pathology, you can make your radiology. It was simple. It was prepatellar bursa. In that bursa, there is synovial chondromatosis. Basically, in synovial chondromatosis, there is metaplasia of the synovium, and these actually then fall off and ultimately calcify. And this is the mechanism which can happen in the joint, which is intra-articular, and this is extra-articular, for the simple reason that bursa are also lined by synovium. And your case final CT scan, which you did well to pick up the findings. And what I liked was that you were talking through the case, which was good. And the key thing is that if we go to the lung window, so we can see a bit of pneumoperitoneum where I am pointing out. Of course, you could have asked for a coronal. It's fine because you picked up the finding on axial. There is pneumoperitoneum, for example, here. Now, as we go, look at these. Look at this, which the candidate pointed out very well. you can see bubbles. Look at these bubbles, just like the bariums which I was showing you. And you can see all of these bubbles right and left. And of course, there